Today's module is on First CMC Arthritis or Synovitis. CMC here standing for carpometacarpal joint. Sometimes this is called the basilar joint. And it's a joint between the carpal bones, or the bones of the wrist, and the thumb metacarpal bone, which is this long bone here. This is an important diagnosis to understand because patients often develop this problem as part of their daily activities or their work activities. And if they are not adequately diagnosed, it can lead to terrible loss of function. One also needs to distinguish this from other diagnoses which might be more treatable or alternatively treatable, such as carpal tunnel syndrome. Benefits are that early diagnosis leads to early treatment, leads to patient maintaining function as much as possible. When we get into the exam room, I'll discuss more history and risk factors as well as specific exam findings. Thank you. Okay, so for first CMC joint arthritis, or sometimes synovitis, synovitis means there are not major structural changes by imaging, but there's actually inflammation of the joint. And again, this is sometimes called basilar joint arthritis. And even just as demonstrating on myself, that's a joint that's between the carpal and metacarpal. It's almost a little squared off in my case, but a little hard to see that. There's the squaring right there. And that squaring sometimes is an early sign of this being a problem. It's often seen in certain industries, such as electricians who have to do a lot of forceful gripping with conduit, sometimes food servers. Sometimes it's patients who don't really have a heavy, forceful grip need in their work, but they're just predisposed. They might have hypermobility, generalized hypermobility, or genetic susceptibility to this type of problem. And as I said, there's often a squaring off. We don't see it much here in our patient Jennifer, she's younger, but you would actually see sort of a squaring off of the CMC joint, the joint between the metacarpal and the carpal bone. Okay? And typically what you get is a focal tenderness right there at the first CMC joint, and not much elsewhere. All right, you're looking in your differential diagnosis, you're thinking of Deckervein's tenosynovitis, and we talk about that elsewhere, or carpal tunnel syndrome, usually not very tender in this part. So it's a very focal tenderness, and you can often clinch the diagnosis by doing a passive circumduction of the first CMC joint. So you stabilize the hand and wrist, and you just roll that around. Patients are not happy with you when you do that. If you have ultrasound at your disposal, you'll actually see little osteophytes and joint narrowing on ultrasound. Treatment it can include, for example, a thumb spica splint. Often you can get one over the counter, but if you really want something that's functional for a patient, you typically have to send them to hand therapy, and they get a very sort of specific functional one that fits nicely for the patient but still lets them do some activities. Modification of what one does in their work. So even in my example, 20 years ago, I noted that I was developing pain around the first CMC joint, and I realized that the way I examined patients was not really ideal for that joint. I was overexerting that joint, and I changed the way I did my physical exam in order to relieve that joint more and reduce stress on the joint. If typing aggravates, you might look at, for example, a voice recognition system and other kinds of modalities. But this can be career-ending for some people. Other treatments include PRP, platelet-rich plasma injections. We do those in our clinic. And there are orthopedic surgical solutions. I won't get into the details here because I don't know the details very well, but I know they've at times tried to replace the joint, and at other times they try to fuse that joint. And not something for the lighthearted. And you really have to weigh cost versus benefit as a patient regarding surgical intervention. Okay, I think that's it. The only other thing I'd say is you can confuse this with carpal tunnel syndrome. Both will present with some atrophy around the thenar muscles being abductor pollicis brevis and two other muscles innervated by the median nerve. The key difference is that with this condition, with basilar joint arthritis, when you test abductor pollicis brevis, hold the thumb up, that's usually very painful for the patient in this condition, but not, for example, with carpal tunnel syndrome. Again, one of the themes in our modules is distinguishing between neurologic weakness, which is usually painless, and musculoskeletal weakness, which is accompanied by joint or tendon pain.